Hello, I'm Donal McCauley and welcome to medicsvoices.com, where we talk to the key opinion leaders in health and medicine around the world. Today I'm talking to Wendy Norman, who really is usually in Vancouver, but today is in Geneva. But let's start at the very beginning of your whole academic journey, Wendy. So tell me about where you started in practice and when you got the academic bug.
Yes. Well, I was a rural GP for many, many years. I had done my training at Queen's and at the University of Alberta, and I went into practice in rural coastal BC in a fishing village, full service general practice, and really had been practicing there for 10 or 12 years, providing everything from palliative care, emergency services, obstetrics care, and family planning services up and down the coast in the volunteer organization.
So tell me about practice.
I loved being a full service general practitioner, particularly in a small town, about 10,000 people on the Sunshine Coast, seashell of BC, maybe spread over 100 kilometers, 3 or 4 little communities, a lot of people working the land, a lot of artistic community, a fair retired segment. And as part of the community, you were friends and neighbors with the people you were looking after. So really, it was a very enriching environment, and one that I felt quite honored to have a chance to have my first practice years there.
So then you thought about academia. How did that begin?
Because of my marriage, I needed to move into Vancouver. In fact, not initially once we were married, but after we had our second child on the way, we realized we were going to have to, my husband in Vancouver and myself, 2 to 4 hours away in this small village, would have to live in the same spot. And so moving into Vancouver, I focused my practice really just providing family planning services at family planning clinics, and found this, particularly providing abortion services to be immensely satisfying. You would see people at the most stressful time in their lives, and with a relatively simple, safe, straightforward procedure, all of a sudden their future opened up. They had the chance to get out of that wretched relationship, or to return to their education that they'd always wanted to do. They had this chance in their life to sit and look at who they were and where they were, and realize where they wanted to go, which wasn't continuing on with an unwanted pregnancy. And so this is really what led me to the academic bug, to start into research. I could see so clearly the kinds of barriers people had tried to address that had left them in a situation trying to make this wretched, very difficult decision about what to do with an unintended pregnancy, and how really we could look upstream to help people time and space their pregnancies.
So let me bring you back. So you're in Vancouver and you're in clinical practice. How did you make that transition? What was it that brought you into academia?
Well, the fortunate thing, and all of our GP colleagues will probably recognize this, and you yourself, is our practice is a lot about getting to know people, to understand their context, their community, the people around them, how these factors have interacted with their health. And I think in talking with people with unplanned, unintended pregnancies, the factors are no different. You're really listening to what's going on in people's lives, and the challenges they've had to face, and the difficulties that they go forward with. And so in listening to these stories for many years of the challenges people had faced, it was fairly clear in my own mind that we could be doing things as a health system that potentially could improve this. And I happened to be working in the BC Women's Hospital, main family planning services, and BC Women's Hospital and the Provincial Health Services Authority of British Columbia decided to set up, in concert with UBC, a research institute, the Women's Health Research Institute. And they sent people around to the different clinical programs to say, listen, is there anybody who's thinking of research questions or who has questions? And my hands both shot up. I had a huge raft of questions that I felt needed to be asked and answered. And you know, Domino, that was maybe 15 years ago now, and I've just been so enjoying the chance to ask and answer questions.
I mean, there are so many people listening to this who have spent a long time in practice, have these research questions, and would like to be able to answer the questions. But was there some particular introductory program that brought you from being a neophyte to being a researcher?
Yes, it's a good question. And at this stage, I had two small children in primary school going into middle school. And during my pregnancies with those kids, I'd done a master's part-time. So that gave me a little bit of some of the foundational skills to be able to move forward towards research. Master's in public health is good for this. Mine was in epidemiology, very similar. When I began to, with the support of the Women's Health Research Institute, want to start to design studies and ask questions, I noticed that our UBC Department of Family Practice offered an enhanced skills program, the clinician scientist program. And so I enrolled as a clinician scholar, which is at UBC a half-time position for 2 years, where you get mentorship and support and monthly meetings with colleagues to be able to talk about your process and learn the different steps as you go towards it. As that sunsetted, I was accepted into a program at the University of Western Ontario, a remote program, the tutor program for transdisciplinary understanding of health research. And this was also exceptionally helpful for me in terms of mentorship of peers that are primary care practitioners and family doctors doing research.
That's terrific. Now tell me about the master's.
I did do a diploma in tropical medicine during the time that I was in the coastal fishing village in Seychelles. They had a program there to support the rural doctors to take a year away as a sabbatical. And I had volunteered to work with Doctors Without Borders, Médecins Sans Frontières, in Africa, and I did a 3-month diploma in tropical medicine in Liverpool before going and doing that work with Médecins Sans Frontières. So I guess I feel like I've been in university all my life. I keep going back to study at different intervals, and it was maybe 5 years later when I completed the master's at UBC, part-time over several years while I was in full-time practice and with 2 small toddlers. But again, it's that fascination to be learning and to understand how you would have more tools to be able to answer questions better, to be able to provide better care for the patients we look after.
So as you continued on this academic career, many academics would say, hang on, you got this the wrong way around, because now you're doing a PhD at this stage.
Yeah, so it's true. I began in research and started to get CIHR grants. I had wonderful mentorship from members of my Department of Family Practice at UBC and a range of other experts in non-family physicians, but experts in their research fields. And I think as a family doctor, running a program of research is so like many of our situations where we're a team leader in running a team care for our patients. And so approaching, using all those family doctor skills to be able to lead a team, find the people that have the different skills that I don't have to be able to conduct the different kinds of specific research. But as the family doctor, I was able to articulate the important questions and to be trusted by in the policymakers and the health system decision makers who could use the evidence of the answers to the questions that we were looking at. So a lot of my research is around wouldn't providing free contraception at different stages in people's lives be an effective measure to help better health outcomes and lower health system costs. And so you need the trust of the decision makers and the health system people. And I think as a family doctor, we're uniquely placed to be able to do that, not only to bring together and lead a research team, but to be ready and in fact integrated from the word go, connecting to the people who can use the results of the research and make it happen. That's not exactly the question you had asked, which was I think a little bit more about.
So what I'm really interested in is what is your PhD on, and how did you get yourself into this position?
Yes. So once I'd been a few years in getting research grants and conducting these studies and starting to change some of these health policies, I really felt that there were so many of the skills that my team members were bringing in their research skills that I didn't really have. I knew what we needed to be able to ask and answer the question that was before us, but I didn't have the specifics on how to do an analysis of this kind of data or how to set up analysis of that sort of data. And I was relying on others to assure me that their analysis was top notch. So I wanted to learn those things myself, and I enrolled at the London School of Hygiene and Tropical Medicine in a sort of distance part-time PhD. So I've been working with my supervisors there to be able to write some papers on research I'd already conducted in Canada where I have the data available and want to get those papers out. But the part I just absolutely love is that there isn't even one session that I would have with my supervisors where I'm not learning something that I didn't know I didn't know. You know, at this stage in our lives, if there's something we realize we don't know, we can go find out. But here, they're teaching me things I didn't even realize I didn't know. And I just can't tell you how much I enjoy that process. So you know, we'll move along. Maybe we'll get somewhere with it. Maybe we won't. But in the meantime, the quality of the research I'm doing is better because of the mentorship that I'm getting from outstanding researchers who are able to tell me that I've got it all wrong and I've got to approach things differently and I've got to learn and read more about this or that, things I wouldn't have known to do.
What I really love is your approach to academia, moving from being embedded in practice to doing the PhD at this end of your career. But you're very different in another way. And that is, you're not an academic sitting in your office. Your advocacy work is fantastic. Tell me about your advocacy work for women's health.
As we started to look at what upstream factors could help people better time and space their pregnancies, as I mentioned before, one of the clear pieces was people weren't able to afford the better kinds of contraception that are more effective that they would want to use if cost weren't a barrier for them. And so we began a whole series of studies that looked at contraception cost effectiveness. And being a family physician and working in hospitals and working in team care, it was really clear that we needed to have engaged right from the beginning the people who could change policies or systems based with on the findings that we had. And so one of the things that really worked well being a family physician was that I was already embedded at BC Women's Hospital and was able to talk to the system leaders in that setting to say, you know, we really could make a difference, not only for the people that come to our hospital, but for all of the province, if we were able to conduct this research and then translate it into policies such as perhaps free contraception for all. And the system leaders at BC Women's Hospital said, you know, you need to speak to so-and-so. And so I kept getting introduced by a person who trusted and knew me to the person higher up in the decision-making chain. And eventually, I started meeting regularly with BC's Chief Provincial Health Officer and with the Minister of Health at BC and a number of decision makers within the ministry. And they became engaged in informing our research. What data, what questions should we be asking people on a survey? What data will you need in order to support this decision? And because they were engaged at the beginning of the research, they had the kind of lead time that policymakers need to put in place the agreement across their policy framework to be able to make a change once we had our results and to act on them very quickly. And in fact, for several of our studies, we've seen provincial policy changes in BC before we've had our papers written. Because the policymakers were sitting on the team, watching the data come in, watching the preliminary analyses, looking at the analyses that we were about to present at conferences, and making their decisions on policy based on those.
So here we have now three corners. We have clinical practice, we have research evidence, and we have policy. But there's something else you do which is remarkable, and that is you're very active in the media. Tell us about your media contributions.
Well, I think these are another form of doing what we're trained to do as family doctors. Our hope is that we can help people to find what they need to know to be able to help their health in the way that they feel that works in their context. And I see interviews with media as part and parcel with that, with the additional factor that some of the people who can help with those decisions are policymakers or system leaders, and they're also listening to media. So it is a chance, I think, in some ways more powerful sometimes than writing papers, to be able to get the evidence message out to people that are making decisions, whether it's the decisions in their own life, the health for themselves or the health for their family, or the decisions of healthcare workers on the care they will deliver, or of the systems on the services they can design, or the policies for how you will fund the provision of care in a province or a country. All of these people listen to media. And in some ways, being able to put across your evidence in a way that makes sense to those people in these short bits on media is, I think, an important role for family physicians and researchers.
So as we finish up, I'm sure anyone listening will agree with me when I say that one of the awards you got was the most appropriate one could ever think for you, and that is a woman of impact. So what's the next piece of work you're going to do, Wendy?
Well, thank you. It's I think there are always more questions than there are time. As you know, the work that we did to make contraception free in BC is now moving nationwide, and we're fairly confident that contraception now will come as a universal free part of our health system for people in Canada. So a lot of our work then will be backing up and measuring the impact of those policy changes. At the same time, we're working to make abortion services more accessible, to make knowledge for people around their choices for unintended pregnancy more accessible. And I think at the moment, we want to improve also safety for abortion services. And in Canada, that really means looking at our rural and remote populations and trying to improve the options that people in those situations have. So we've just recently, a few weeks ago, been awarded over $3 million from the CIHR to be able to do a 7-country project looking at rural and remote provision of abortion in Australia, in northern Sweden, in the Scottish Out Islands, and around the world, to be able to see what are the factors that are important and that we need to know to ensure safe but accessible abortion care for people in those situations.
Wendy, thank you very much for sharing your life, your career, your ambition, and your tremendous work for women's health. Thank you very much indeed.
Pleasure to talk with you, Domhnall, anytime.